Welcome everyone back to part 13 of the 150-part IPDRG Masterclass right here on Decode Healthcare with Harshal. I'm so thrilled to be with you again as your lead instructor. Today, we're diving deep into the absolute complexities of inpatient diabetes mellitus coding. We're going to look closely at categories E08 through E13, dissect combination coding for acute complications like DKA, and definitively tie all of this back to the MSDRG severity impact.
But real quick before we jump in, just a friendly reminder, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Your support is literally what helps us keep building this incredible community of focused learners.
Okay, let's take a quick peek at today's syllabus. We'll start with an introduction and recap, then break down the diabetes categories from E08 to E13. After that, we'll cover combination coding and linkage, dive into acute complications like DKA, discuss insulin therapy, and wrap up with the MSDRG's severity impact.
All right, let's kick things off with Section 1, Introduction and Recap.
I just want to take a second to recap our previous explainer, Part 12. Remember, when a patient presents with both acute kidney injury and dehydration, there's absolutely no blanket rule stating AKI must always be sequenced first. You really have to base it on the primary reason for admission. And don't forget, chronic kidney disease always requires specific staging codes, like the N18 category, to accurately reflect the patient's severity.
Moving right along to Section 2, ICD-10-CM diabetes categories E08 to E13.
So there are 5 essential categories that serve as your starting point for literally any diabetic patient. E08 is for diabetes due to an underlying condition. E09 covers drug or chemical-induced diabetes. E10 is type 1, 11 is type 2, and E13 is for other specified types. Now here is a golden rule you absolutely need to memorize. If the specific type of diabetes isn't documented in the medical record, your default is always E11, type 2 diabetes mellitus. Also, keep in the back of your mind that while type 1 is often referred to as juvenile diabetes, age actually isn't the sole determining factor.
Now, when we look at the chapter-specific rules for these key inpatient diagnoses, there's an important reminder. Every single diabetes mellitus code must specify the complication. We can't just code diabetes in a vacuum, right? We need to know, is it with neuropathy, nephropathy, retinopathy? Capturing that specific complication is what tells the true clinical story of the patient.
Which leads us perfectly into Section 3, combination coding and manifestation linkage.
The really crucial thing to grasp here is that diabetes codes are combination codes. They're incredibly efficient because they capture 3 things all at once: the type of diabetes, the body system affected, and the specific complication. And you've got to remember the presumed relationship rule. When you see words in the index like due to, secondary to, and especially the word with, that dictates a legally presumed causal link. So, if a patient has diabetes and chronic kidney disease, you presume they're linked and code them as such, unless, of course, the provider explicitly documents that they're entirely unrelated.
Looking at some everyday clinical scenarios, let's focus on Case 2, Type 2 diabetes with CKD Stage 3. We use E1122 for the diabetic chronic kidney disease, and then we follow our code also rule by adding N1832 to specify its Stage 3. Or take a look at Case 5, Type 1 diabetes with neuropathy. That drops into a single, beautifully elegant combination code, E1040.
Let's turn up the heat a bit with Section 4, acute complications, focusing on DKA and hyperosmolarity. We really need to talk about diabetic ketoacidosis, or DKA. When you're reviewing a chart and you see clinical indicators like extremely high blood glucose, ketones in the urine or blood, metabolic acidosis, and maybe severe nausea and vomiting, your coding instincts should immediately fire. You need to navigate straight to the E10.1x or E11.1x categories. For instance, E11.10 captures type 2 DM with ketoacidosis without coma. This is a severe acute complication that heavily impacts the patient's care and the hospital's resource utilization.
All right, moving right into Section 5, reporting drug therapy and temporary insulin.
Let's think about the medication administration record, or the MAR. As a clinical coder, you're essentially a medical detective. If you're reviewing the MAR and you see insulin being given day after day, but you look at the face sheet and there is absolutely zero mention of a diabetes diagnosis, what do? Well, you don't just guess. You must generate a concurrent or retrospective physician query to clarify exactly why that insulin is being administered in the first place.
And here's a massive compliance factor when it comes to insulin codes:
We have Z79.4 for long-term current use of insulin and Z79.84 for oral hypoglycemics. You assign Z79.4 if the record clearly indicates the patient routinely relies on insulin at home. But, and this is a big but, you absolutely do not assign the Z code if insulin is just being given temporarily, like, say, on a sliding scale just to bring acute blood sugar levels under control during their hospital stay. You only code it for established, long-term reliance.
Finally, we've made it to Section 6, MSDRG Severity Impact and CDI Queries.
Let's do a direct comparison between two charts. Chart 1 shows pretty vague documentation. The provider just wrote type 2 diabetes mellitus without complications, which codes out to E11.9. This naturally falls into a lower-paying DRG because uncomplicated diabetes is not a complication or comorbidity. But over in Chart 2, the clinical documentation integrity specialist actually queried the provider, who then specifically documented type 2 diabetes with ketoacidosis. That single active specificity completely changes everything. By accurately coding that acute DKA as E11.10, it triggers a major complication and comorbidity, or MCC, and when you pair that with a principal diagnosis of sepsis, the relative weight of the DRG more than doubles to 1.9015. So this isn't just about getting paid more, it's about legally and accurately reflecting the intense resources required to save this patient's life, and by doing so, fully protecting the facility's legitimate revenue.
So, I want to leave you with this provocative thought to make sure you're always hunting for that missing specificity in the chart. Are your clinical queries capturing the precise diabetic complications needed to reflect your patient's true severity of illness? Never just settle for a vague history of diabetes if the labs and treatments are screaming that an acute complication is present. Get the DRG right the first time.
Thank you so much for joining me for Part 13 of this Explainer Masterclass series. You are doing fantastic work mastering these complex coding guidelines. And as always, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you in Part 14.